Stop scrolling and give me a few minutes because this video will save you on your exams. Crohn's disease versus ulcerative colitis. Super high yield, you need to know the differences. First, location. Crohn's disease can happen anywhere from the mouth all the way down to the anus, which is why I've drawn out the entire alimentary canal. But the classic location is the terminal ileum and colon. The key thing is Crohn's disease has skip lesions, which means that you will see diseased bowel next to completely normal bowel. Now, the rectum is completely spared. It's normal. Now, ulcerative colitis, as the name suggests, colitis, colonitis, inflammation of the colon. It only involves the colon, and it always starts from the from the rectum, and spreads upward continuously. There are no skip lesions. So, Crohn, skip lesions. Ulcerative colitis, continuous lesions starting from the rectum. Now, morphology. Crohn disease causes transmural inflammation, which means all layers are affected. And if all layers are affected, formation of a fistula is possible. This is why you get fistulas. You also get strictures, bowel thickening, creeping fat, and cobblestone mucosa. Remember the C in Crohn? Cobblestone. Okay, now histologically, this is unique. You see non-caseating granulomas. Now, because the terminal ileum is commonly involved, bile acid resorption decreases, and eventually that can result in cholesterol gallstones. Another thing to know that's super high yield is formation of calcium oxalate stones, because calcium binds oxalate in the gut. But in Crohn's disease, fatty acid binds to calcium instead, which leaves oxalate free to be absorbed in the blood and eventually leads to kidney stone formation. Which type? Calcium oxalate. Now, ulcerative colitis only affects the mucosa and the submucosa. So you do not get transmural inflammation, so fistulas are very uncommon. Instead, ulcerative colitis causes crypt abscesses, ulcerations, as the name suggests, ulcerative, and bleeding. Okay, bleeding. And on imaging, you see that the hostra that's normally present in the colon is going to be lost. So what's going to happen is you get smooth colon, which is classified as the lead pipe appearance. Okay, important to know that lead pipe appearance. Now, the extra intestinal manifestations of ulcerative colitis is gonna be primary sclerosing cholangitis. This is so important and super high yield. You're gonna be given this, and you're gonna be asked, what other thing could this guy have? And that's when you're gonna go with ulcerative colitis. It can also lead to toxic megacolon and increase the risk of colorectal carcinoma. Now, important part. Both diseases can be monitored with fecal calprotectin. Fecal calprotectin. Why is this important? Because it helps us in distinguishing between inflammatory bowel diseases and IBS. So it helps in distinguishing from inflammatory bowel disease from IBS. If this helped, save it, because I guarantee this will show up on your exams.